Hi, everyone. I am Nathan Olafsen. I am an assistant professor in the Department of Orthopedic Surgery in the Division of Physical Medicine and Rehabilitation at Washington University. I am one of the co-directors with Dr. Suhu of the Resident and Medical Student Workshop for AAP. I also am the Associate Residency Program Director, and I help direct the Musculoskeletal Sports and Pain Medicine curriculum for our residency program. I'm going to share my screen, and then I will be speaking on basics of electrodiagnostic medicine. So I have no financial disclosures or conflicts of interest. So first off, let's start with what is an EMG. Often you might have heard of this. Some of you have even probably performed these. Really, an EMG refers to two tests. In the picture on the left, this is a picture of a nerve conduction study where an electrical impulse is put through a nerve and then picked up distally over a muscle or over skin to assess how the nerve is carrying electrical information through it. The picture on the right is an EMG needle, and EMG also stands for electromyography. The needle is effectively a sensor that picks up the electrical activity of muscle. So why do we do it? Why are EMGs something that is really vital to and fundamental to being a physiatrist? Well, it helps us assess for peripheral nerve or muscle pathology. It's really not a tool to assess for upper motor neuron pathology, although some non-specific findings on EMG can be present. We have other tools for that: CT scans, MRIs, our clinical assessments. Common reasons why an EMG might be ordered or why you or your attending or other residents might be performing them would be things like weakness, numbness, or neuropathic pain that could have a peripheral nervous system source. Common pathology that you might encounter and why this might be done or what an EMG might find. If we look at the picture on the right, we're going to indicate some of the places where common pathologies might occur in this system. So where the first blue X is where radiculopathy might occur: cervical radiculopathy, lumbar radiculopathy. This occurs distal to the motor neuron that you can see represented in the spinal cord, and proximal to the dorsal root ganglion cell body. This is an important thing to understand as to what may or may not be abnormal on our testing subsequently. The next X would represent where plexopathy, whether it be brachial or lumbosacral, if there was an injury there, we could assess for that as well. Peripheral nerve injuries, whether that be something more common like carpal tunnel syndrome or maybe a fracture causing a peripheral nerve injury. Neuromuscular junction disorders and myopathies. These are all pathologies that an EMG and nerve conduction studies can be helpful to assess for. Furthermore, we can assess the type of injury. We can assess it if it is an injury to the myelin only, or if there is also an injury to the axon itself. Really vitally, as represented by the blue X's, we can localize where the lesion or where the injury has occurred. And then that, plus an assessment of severity, can help guide prognosis and guide further treatment. The dreaded picture of the brachial plexus, but this is a picture to represent how, when you are an electromyographer, you are thinking about this anatomy in real time. When you are making decisions as to what muscles to test or what nerves to test, we need to have mastery of this anatomy so that we can think in real time and localize the lesion with our electrodiagnostic testing. So let's dive a little bit more into the specifics. We're not going to get too concrete. You're going to get a lot of time to practice in the future workshop. But so we have some shared understanding about what nerve conduction studies are. They're really the shocks. That's what patients will call them. And really, that's just an imparting of an electrical impulse through a nerve, and then we are picking up the communication of that electrical impulse with our electrodes. There's going to be an an amplitude and a speed associated with these. As you can see, we have these waveforms here, these compound motor unit action potentials, and compound motor action potentials, apologies. And what that's doing is it's a summation really of the electrical signal that's imparted through the nerve and then picked up over the muscle, okay? That amplitude, that speed are things that we can assess to see if there's any normal or abnormal nature to the finding. Also, we can assess the latency, the time from when the stimulation occurs to when the action potential shows up. That latency may be normal when compared to normal data, or could be delayed, possibly. And that delay could indicate specific abnormalities. In this cartoon, we're thinking about like the distance and the time associated with a stimulation to be done and then to be picked up distally. So the speed with which that occurs, we can assess, at least with a motor conduction or a sensory conduction study, as a latency of some type. In a motor conduction study, this is a distal motor onset latency, or a sensory study, this could be a peak sensory latency. We can compare those to normative data, and in the example in the bottom left, that is shorter than the latency on the example on the bottom right. Also, since we have not only a time that it takes for the impulse to go through, and if we measure the distance between where we stimulate, we can calculate a speed, a conduction velocity, as you see is the bottom number, which has a meters per second associated unit with it. The example on the bottom left is normal for a distal latency and a normal conduction velocity in this example, whereas on the right, these are profoundly slowed. The distal latency is delayed and the conduction velocity is substantially slower than the other side. This could be suggestive of a demyelinating process. Similarly, we would want to assess the amplitude, the strength of the response of our stimulation. In the bottom left, you can see the amplitudes are much higher, the height of the response is bigger than it is on the left. Amplitude of, say, 9 versus amplitude of 2. This could be suggestive potentially of an axonal injury, where there's just less nerve to conduct the electrical impulse to the target. Let's dive more now into EMG, or electromyography. In this, your patients may call this the needle test, okay? What you're doing is testing motor units in an individual muscle to see how they're working. We assess the muscles at rest as well as when the muscle is activated. An important concept to understand when thinking about EMG is the concept of the motor unit. A motor unit, each muscle fiber in a muscle is part of a motor unit, but maybe separate motor units. The cartoon on the right kind of helps understand this. The anterior horn cell, the axon, as well as the associated muscle fibers to that axon represent a motor unit. In this cartoon, you can see that there are actually 3 separate motor units that are making up this specific cartoon muscle. In our EMG, we're sampling these and assessing these motor units. What we see electrically on our testing are action potentials that represent these motor units, or motor unit action potentials. That's represented here by the green arrow. The EMG needle would be placed adjacent to or within a muscle, and we would pick up the activity of some of the muscle fibers that make up that motor unit. When we assess the muscle at rest, the muscle should be effectively electrically silent with a brief amount of electrical activity when the needle is moved. This is called insertional activity. If there is more or less of that insertional activity, or if there's sustained activity, that may represent abnormality. For example, if there's activity when the needle is been moved and then stopped moving, but is sustained activity when the muscle is at rest, this could represent spontaneous activity, such as positive sharp waves, which are represented by the first arrow, or fibrillation potentials. These can indicate muscle or nerve pathology. This example would indicate that there has been injury to the axon that goes to the dots representing muscle fibers, and the EMG needle is picking up the spontaneous activity below. We can also, when there's an abnormality to the nerve, we can pick up what the motor unit action potential is doing. What does it look like? What is its characteristic? This can also be true if there's abnormality that's primarily to the muscle. We can assess if other motor units have started to pick up some of those muscle fibers where they branched in this example. Here you see an EMG needle in this cartoon placed next to muscle fibers. And one motor unit, the bottom motor unit, has sent extra sprouts to pick up some of the muscle fibers for the motor unit above that was injured in its axon. That extra sprouting may change the typical appearance of the motor unit action potential as you see below, where there's more phases or where it goes up, down more, and it's wider. Okay, the characteristic, the size, the length, the height, etc., the recruitment of motor units all can indicate certain types of abnormalities. Let's dive now in a little bit into clinical scenarios. So one of the most common reasons why we would perform electrodiagnostic testing would be hand numbness, and many times we find carpal tunnel syndrome. In mild carpal tunnel syndrome, typically this represents a demyelinating injury to the median nerve at the level of the wrist. Because it's a demyelinating rather than axonal process, we would expect that the latency of the motor study might be prolonged or slowed, and the peak latency of the sensory response might also be slowed or prolonged. But given that the axon is normal, we would expect that the needle EMG for the most part would be pretty normal. To a different and yet still very common example would be radiculopathy. The MRI on the right is showing a very large posterior lateral L4-5 disc herniation extrusion that is pushing on the traversing L5 nerve. You can't even see it. The arrows are indicating the disc. In this, since the injury is happening proximal to the dorsal root ganglion, think back to a couple slides ago, we think that the sensory should be normal. The cell body of the sensory nerve and the axon of the sensory nerve down to the skin of the leg should be fine. The injury is proximal to that. Whereas the axon of the motor nerve very likely could be injured by this big disc pushing on it. As a result, sensory studies like the sural nerve or the superficial fibular nerve likely would be normal, whereas EMG abnormalities would likely be seen in muscles that get innervated by the L5 nerve. Finally, let's talk about kind of big buckets to think about when you're starting to build knowledge around electrodiagnostics. There's really three big categories of things you need to know to become an effective electromyographer: technique, anatomy, and pathophysiology. A lot of knowledge needs to be acquired about how to do things correctly, what buttons to push, where to stimulate, how to move the needle around, where to put the sensors on the skin. There's a lot, and that's a kind of a steep learning curve that happens in residency. You also, though, need to know the anatomy in and out of what muscles are innervated by what nerve, how does the nerve get there, where does it go through the plexus. And then finally, an understanding of nerve injury. When a nerve is injured, how long does it take, or what are expected timelines for abnormalities to show up on electrodiagnostic testing, and understanding the difference between an injury to the axon of a nerve versus an injury to the myelin only of the nerve. I hope this was a useful introductory talk. We look forward to your participation in the workshop. We're excited to see you in person, and please bring all your questions and thoughts. Be well and travel safe.